Greetings again, everybody. We're going to talk about some problems, surgical problems involving the neonate here. So for the pediatric surgery section, I divided this up into 4 different subsections. The one we're talking about here are problems that primarily involve the neonate. Another section will be devoted to problems that involve bilious vomiting. Another section will be devoted to topics that may happen in the neonate, but can also happen later in infancy as well. And then I'll also talk about some surgical topics that relate to older children. So we're going to talk about these topics here. We'll start out with omphalocele. So the omphalocele is a defect of the abdominal wall musculature, and it results in a protrusion of the abdominal viscera. Primarily, we're talking small intestine, most notably stomach, parts of the large bowel, and then spleen too. But most notably, the small bowel. That's probably going to be what you see when you look at an omphalocele if you see organs. So these organs are protruding through the abdominal wall and actually into the umbilical cord. And this umbilical cord is what you're going to note that's going to help you distinguish this from the next thing we're going to talk about, which is gastroschisis. Because this umbilical cord, you can follow it to the sac, and the sac contains the protrusion of organs. So these visceral organs are visible, but they're covered with a protective sac. And you can just follow the umbilical cord straight down to this protrusion of organs. It's right over the umbilicus. Usually these days this is diagnosed before the baby is even born, antenatally via sonography. It's associated with trisomies, so 13, 18, 21 are usually the babies that are born. It's also associated with Beckwith-Wiedemann syndrome, the neural tube defects. Of course, anytime you have a baby with a congenital issue, you're always thinking maybe this baby also has cardiac defects, since those are so common, and then other congenital anomalies. So the omphalocele is associated with other congenital problems. What do we do? So this is diagnosed, like I said, either antenatally or the baby's born and it's staring you right in the face. You don't need to do any tests. You can see the omphalocele flat out. So we just go straight on to treatment then. So the best initial step is going to be to cover the exposed viscera with a moistened sterile gauze. One of the big problems in omphalocele and gastroschisis is that the baby can lose fluid, and by losing fluids that can disturb the electrolytes because all of this viscera is exposed, which shouldn't otherwise be exposed. So it's very important that this sac, which contains the viscera, is covered and it's moistened so that you don't have any extra fluid loss. We also want to cover it because we don't want there to be an infection, because this is exposed tissue that shouldn't otherwise be exposed. This will also help against protecting against infection, although the protective sac usually does a pretty good job of that. What else are we going to do? This is going to be a child that is not going to be eating anything per mouth. They're going to need surgery anyway. So we're going to do NG decompression to decompress the GI tract. And because they're not taking anything per mouth, they're going to be on IV fluids and nutrition. And that's also important to make sure that we're maintaining a good hydration and good electrolytes. Definitive therapy, of course, is surgical, and that's going to depend on the severity. So if it's just a minor defect, then you can probably close it all at once, place it all back in all at once. But in larger defects, you'll probably need to do it in stages. So you'll put some of the bowel back in, some of the abdominal contents, stop and wait a day, and then do more in stages. Because the problem is if you put too much in, remember you're dealing with a fixed space here in the peritoneum. If you put too much in, you can press up against the diaphragm, you can press up against the inferior vena cava, and that can cause problems. We want to avoid that. So those are actually some of the complications, the respiratory compromise and lower extremity edema due to compression of the inferior vena cava. So the definitive treatment is surgical to replace the contents back into the abdominal cavity, but you have to do this. Slowly. So here's a baby with an omphalocele. And you can see here, this is the cord has been cut right here. You can see this small bowel here. Okay, gastroschisis is kind of similar to omphalocele in that you've got contents from the abdomen that aren't in the abdomen. But what gastroschisis is caused from is an incomplete fusion of the abdominal wall, which results in a free herniation. So now what you have with gastroschisis is you've got abdominal contents that are just free floating outside the body. There's nothing covering it, no protective sac, no umbilical cord, nothing. So it's just literally just bowel outside of the body. So unlike omphalocele, gastroschisis doesn't have a protective sac, and the viscera are in acute danger. These are eviscerated organs. This is also associated with trisomies. Approximately 50% of all gastroschisis patients are also small for gestational age. This can also be diagnosed before birth via sonography. The major complication of gastroschisis, as you can imagine, is infection and inflammation of the organs that are outside the body. So chemical peritonitis and sepsis, and those will destroy bowel. And that's primarily what we're concerned with, both with omphalocele and gastroschisis, is small bowel. That's going to make up the majority of organ that's outside the body. So chemical peritonitis and sepsis will destroy the bowel, and this is what we want to prevent. So the best initial step, just like omphalocele, is going to be to cover the abdominal contents with moistened sterile gauze. This is going to require relatively urgent surgery, unlike the omphalocele, where because we have that protective sac, we've got a little bit of protection. It's still going to be surgery quick, but gastroschisis is a much bigger emergency. So we're also going to do NG decompression to get ready for surgery. Infants should be placed on broad-spectrum IV antibiotics. With gastroschisis, because you have just exposed bowel, you're at a much greater risk for infection, and that infection can cause inflammation, death of the bowel, and it can also cause sepsis. So we want to have the baby on broad-spectrum IV antibiotics, and then IV fluids and nutrition. Just like with omphalocele, with gastroschisis, we're concerned about fluids and electrolytes. So the urgent surgery should be done within 48 hours, and usually this is going to wind up being a staged closure. And in between those stages, we're going to make sure that we have the bowel covered. It's so important. So remember what your best initial step is. It's not going to be IV antibiotics. It's not going to be NG decompression, although those are all part of your treatment. Your best initial step for omphalocele and gastroschisis is going to be to cover the abdominal contents with moistened sterile gauze. So here's gastroschisis. You can see this is much different than the omphalocele. And I will note that pretty much always, I've never seen a case where it wasn't, pretty much always the herniated contents are to the right of the umbilicus. So here you can see it's covered with a silo bag. That's just as good as moistened sterile gauze. Moistened sterile gauze is sort of what gets us through initially. The silo bag is what's used in between stages of surgery. Yeah, so you can see here it's to the right of the umbilicus. Okay, esophageal atresia. So this is when we're talking about esophageal atresia here, we're also talking about tracheoesophageal fistula because they tend to coexist. This is a heterogeneous spectrum of lesions, varying in their severity and time of presentation, as well as how the esophageal atresia and the tracheoesophageal fistula relate to one another, where they are anatomically. All of them involve an incomplete formation of the esophagus. So I made this little diagram to help you sort of visualize this. So the most common esophageal atresia is the esophageal atresia with a distal tracheoesophageal fistula. So here is your esophagus here in orange, and you're coming down and you have a blind pouch, a proximal blind pouch. And the distal part of your esophagus actually is fistulating with your trachea, and that then goes into the stomach. So you have a communication between your stomach and your trachea via your esophagus. So this is the distal tracheoesophageal fistula. So this proximal blind pouch, distal tracheoesophageal fistula, this is 85% of cases, so this is going to be the majority. And what happens is that the baby is not able to swallow things. They swallow and it goes right down into this blind pouch, and that's going to include saliva, and that's going to give rise to some of the symptoms. In addition, anything that's in the stomach can get into the airway, and anything that's in the airway can get into the stomach, and so you'll see gas in the bowel. Okay, now the pure esophageal atresia doesn't involve a tracheoesophageal fistula. Here you just have a proximal blind pouch and a distal blind pouch. The H fistula is just a tracheoesophageal fistula without atresia, so you've got a communication between your esophagus all the way down to your stomach, but you also have a fistula between your esophagus and your trachea. And then the esophageal atresia with proximal tracheoesophageal fistula is only 2%, and this is just the opposite of what the most common one is. This is where you have a proximal tracheoesophageal fistula and a distal blind pouch. And here, the big problem is when baby eats or swallows or whatever, it goes straight down into the respiratory tract. Now, you can also get contents into your respiratory tract by any of these other ones because of regurgitation in these proximal blind pouches. So you swallow something, you cough it up, regurgitate it back into your lungs. And it can also happen with the H fistula too. So these are all similar in presentation, but they're different in anatomy. But do know that the esophageal atresia with distal TEF is the most common subset. Okay, so esophageal atresia and tracheoesophageal fistula are associated with a sequence in which you see several of the same things in the same baby. So this is known as a vactoral sequence. Now you don't have to have all of these in the same baby, but all of these are associated with one another. So if you have one, it raises your risk for the other. So vactoral is just a mnemonic, and it's what's an acronym, not mnemonic. Anyway, it stands for vertebral anomalies, anal anomalies, primarily imperforate anus, cardiac defects, tracheoesophageal fistula, renal defects, and limb anomalies. So the big thing you're thinking about whenever you have a baby with one of these is the cardiac defects, since cardiac defects are so common. So with a patient with esophageal atresia, we are thinking this baby probably has a cardiac defect, and so we're going to need to do an echocardiogram. But do know that the vactoral sequence, what each of these are, what they stand for, and that they are associated with one another. It's not a syndrome. You don't have all of these together in the same baby. But if you have one, you have an increased risk of another. Okay, now the symptoms of esophageal atresia, as you can imagine, include respiratory distress shortly after birth, either because of the regurgitation or because of feeds, saliva going into the respiratory tract. Therefore, it can worsen with feeding. Regurgitation, you can get just an outward regurgitation of feeds. Excessive salivation. So everybody salivates. And so when you salivate, what normally happens to the saliva? It goes down your throat. And it goes down your esophagus and into your stomach. Well, who can't do that? Babies who have these blind pouches. And so they're going to have excessive salivation. It's not really excessive salivation. It's normal salivation, but they can't swallow their saliva, so it just comes out their mouth. So it looks like they're salivating excessively, and so it looks like drooling. And then they can also have signs of aspiration pneumonia if they get any of saliva or feeds into their lungs. And so that can include fever, tachypnea, and adventitious lung sounds. Another thing you'll notice is a failure to pass NG tube. So that's primarily in these first two. So if you try to pass an NG tube down, you're going to run into a dead end. For diagnosis, the best initial diagnostic test is a plain film. Now, by plain film here, I mean chest x-ray and abdominal x-ray, but this is a neonate, so you don't really need to order chest x-ray or abdominal x-ray, which really is referred to a lot of times as a babygram, because you place the baby on x-ray plate. The x-ray plate's bigger than they are, so you're getting an x-ray of the entire baby, even though you just need the chest and abdomen. And this will show a blind upper pouch in 92% of cases, which should show a coiled NG tube. You should try to pass the NG tube before you take the x-ray, so that when you see a coiled tube, you know then this is a blind upper pouch. It'll be easier to see it. Echocardiogram should also be ordered before surgery, and that's just to help with planning. And also because we're concerned with cardiac defects. For treatment, we do NG decompression, IV antibiotics, because we're concerned of possible aspiration pneumonia, whether it's there or it may come on. IV fluids and IV nutrition, or you can do nutrition via a gastrostomy. So there's nothing wrong with the rest of the GI tract. So if you want, you can place a gastrostomy tube and feed the baby that way. Either way. And then this is repaired surgically, of course. Okay, so the imperforate anus is an abnormal termination of the anorectum, which can include multiple different presentations. So an imperforate anus can include a fistula that opens into the vaginal vault or the peritoneum. You especially see this in girls. It can also involve a fistula to the urethra, and you particularly see this in boys. And it can also involve just a blind rectum with no fistula at all. So imperforate anus is classified based on whether the rectum passes the puborectalis sling, which is roughly where the levator ani muscle is. If it does not cross the puborectalis sling, it's a supralevator imperforate anus, and these tend to be the ones that empty into either they're blind or they empty into the urethra. There's a fistula into the urethra. The infralevator type is where the rectum does cross the puborectalis sling. These tend to be the ones that open into the vaginal vault or perineum. So the symptoms of imperforate anus, usually it's grossly visible. You see a baby with normal genitalia, but then the anus is not there. There's no hole where there should be a hole. It's usually just looks like a little dimple. Also, you can see if you don't notice that, the baby will certainly fail to pass meconium unless there's a fistula that opens into the vaginal vault or perineum. And if there's a colourethral fistula, you can get a UTI. This also, remember, is associated with the bacterial complex. For diagnosis, this is going to be a combination of physical exam, urinalysis, and pelvic radiographs. Pelvic radiographs are going to be important because that's going to show you how far the rectum goes before it terminates. The treatment for imperforate anus is surgical repair. So this should be done immediately for the supralevator types. So the types that that are either blind or they empty into the urethra. So why? If it's blind, you got to have somewhere to get the GI contents to empty. So you've got to do surgery in those ones. For the colourethral ones, we can't just constantly have feculent bacteria going down the urethra. That's going to lead to UTIs, constant UTIs. So both of those are going to have to be corrected immediately. If there is a fistula that opens into the vaginal vault or perineum, that can be delayed until a later time. determined by the pediatric surgeon. But if it empties into the urethra or it's blind with no fistula, you need to repair that immediately. So here's an imperforate anus. There's no hole here, just a dimple. I have no idea what this residue is. Another one. And another one. Okay, the congenital diaphragmatic hernia is a big problem. So this is a failure of diaphragmatic tissues to fuse, and this results in a defect for the abdominal contents to herniate, and they herniate then into the thoracic cavity up through the diaphragm. And so the primary problem is respiratory insufficiency because you've got bowel in your thoracic cavity, and therefore you have reduced ventilatory capacity. There are two places that congenital diaphragmatic hernia can herniate in, and those two places are the foramen of Bokdalic, and this is the most common. It's the posterolateral defect. I'll show you a map here. It's right here, and it's on the left side. And the reason these tend to be on the left side in general is because what do you have up against your diaphragm on the right side? You have your liver. And so that protects the right side. But on the left side, you have no protection, just bowel and diaphragm. So on the left side, you can get the posterolateral Bokdalic hernia. This is most common presentation of congenital diaphragmatic hernias. And it's almost always on the left side, but it can be bilateral in 10%. The foramen of Morgagni is an anterior defect. This is much less common, and when it does present, it's much less severe. So the symptoms, you can imagine if you have bowel all over in your thoracic cavity and your lungs can't expand, you're certainly going to be in respiratory distress. You also have tachypnea, use of accessory muscles, nasopharynx, cyanosis, all of those things associated with respiratory distress. When you auscultate, you'll note that there's no breath sounds on the affected side, which, remember, is the left side almost always. It'll always be on the left side, might be bilateral, but it'll always be on the left side. So you'll have absent breath sounds on the left side. You'll also hear shifted heart sounds, and that'll be to the right because you've got bowel pushing the heart over to the other side, pushing it over to the right. And then another thing you might note, and I couldn't find any pictures of this, is a scaphoid abdomen. So a scaphoid abdomen is just an abdomen that is kind of like empty. So rather than being a bloated abdomen, it's like the opposite. It curves inward, down. Right. So the best initial diagnostic test for a congenital diaphragmatic hernia is chest X-ray, but really you're just taking an X-ray of the baby, and that'll show abdominal contents in the thoracic cavity and the shifted mediastinum, pushing your heart over to the right. What do we do for treatment? The answer is not surgery right away, and the reason for that is because immediately after the baby is born, the lungs aren't completely matured. I mean, they're not matured to the point where we would want them to be. And so what we do is we put them on a gentle mechanical ventilation for a day or two. And this allows the lungs that are there to mature. And so then when you go to do the surgery, the baby has a better chance. So gentle mechanical ventilation, of course, we're not going to be feeding the baby because if you put any food into the bowel, it's going to expand and make the problem worse. So NG decompression, IV fluids and nutrition. After a day or two of mechanical ventilation, you can then do surgical repair. Another way that you can oxygenate the baby is via ECMO. ECMO stands for extracorporeal membranous oxygenation, and this is just a more intense way of making sure that the baby stays ventilated. One of the complications of mechanical ventilation, the reason I say gentle mechanical ventilation, is barotrauma, which can lead to pneumothorax, which would make this problem much worse. So depending on the severity, it's up to the pediatric surgeon whether they want to do general mechanical ventilation or ECMO, but those are both options. With the congenital diaphragmatic hernia, so you see that you've got the bowel all up here on the left side of the thorax, and then of course everything's obscured here because one, you've got heart over here, but you also got lung being compressed up against the right side of the wall. You do have a hypoplastic left lung because you've had bowel up here for so long, but eventually that ipsilateral lung will develop with time after you have done the corrective surgery, and as the child grows up, that other lung will develop. Here's another case, a little bit less obvious. The bowel's up here. Okay, exstrophy of the bladder is protrusion of the bladder through a defect in the pelvic wall. This is associated with anomalies of the pelvis, the pelvic bones, and the genitalia. And a lot of times this is called the Exstrophy's epispadias complex. Epispadias is where the urethra empties onto, it empties abnormally dorsally. Hypospadias, it empties abnormally ventrally. So the symptoms of exstrophy of the bladder is literally just herniated bladder. So you'll have a visibly herniated bladder. Oftentimes this is described as a red medallion, and it's glistening with urine. You do have ureters that are connected to this exstrophied bladder, and so there is going to be urine out, and so there will be urine there as well. A lot of times you'll see part of the proximal urethra too. In addition to exstrophy of the bladder, the patient will also have other problems that are associated with this exstrophy. In boys, there'll be a lack of anterior corporal tissue on the penis in addition to epispadias. And in girls, there'll be a narrow vaginal orifice, a split bifid clitoris, and divergent outward-pointing labia. For diagnosis, this is really easy. It's clinical, but you'll also want to obtain pelvic radiographs to see if they're, to document the other abnormalities. They will be there. I should say, in addition to these genitalia abnormalities, it's also common to see external rotation of the pelvis, abnormal external rotation of the pelvis, shortening of the pubic rami, and separation of the pubic symphysis. So there's bony problems as well. What do we do for treatment? This is kind of similar to the gastroschisis and omphalocele in that we want to protect the herniated tissue. So you'll place a non-adherent film over the protruding bladder and then immediate surgical repair. So here is exstrophy of the bladder. This is the bladder right here. Okay, so this is exstrophy of the bladder in a young boy. So here's the penis here, and can't really see a whole lot else, but there would be a decreased amount of anterior corporal tissue. And eventually, this is going to be cosmetically problematic because the penis will be curved. They call that chordee. And then here in a baby girl, you see the bladder here. The clitoris here is bifid, and the labia are outward pointing, divergent.